the course, but then
Uh-huh.
obviously, you have to be like work in the hospital, gain
Yes, of
experience.
course.
So it takes like 5, 6 years.
Uh-huh, makes sense. Okay, thank you, thank you.
No problem. After my lecture, hopefully I'll be able to like give you some information. Once you inshallah graduate, then you can look at different options. Many universities they offer scholarships in different residency programs all around Russia. You can like check them out.
For me, I don't think I'm planning to do residency in Russia because
Oh,
I don't know, but I'm planning of getting the class and diploma in my uni in KBGO, and then either apply to scholarships either to UK or the US or
oh,
Germany.
that's a wonderful idea.
So I still have so much time, but like this is my plan for now.
Oh, that's good. Inshallah, all the best.
Thank you, inshallah.
No problem.
I actually saw you twice, and I wanted to come say hi, but once I was in a taxi near the main building, and the other time was beside the old building at the end of the park.
Oh, really?
I wanted to come say hi, but I couldn't because in both times I was in a taxi
No, no, no.
going to there. So next
So,
time, inshallah. Yeah,
inshallah.
yeah.
You know, this is exactly why we created this, for people like you to ask other people, how do I do a residency? What's going on in Germany? What's going on here? That's the value of this platform, like you're doing now. And you're certainly welcome to hang around after and off air, because uh, I end the webcast, but still stay on air. So hopefully students will see that, hey, I'm going to hang around, chat with other students, see where
Yes.
I can go do a residency, see where I can do this. And certainly we'll give time at the end of this webcast. So here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hold on, hold on. It's like, oh man, I'm getting rusty. Good day. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. I'd like you to welcome to Neurosurgery Essentials. Gee, the name is escaping me. Neurosurgery, what's it called again?
Neurosurgery
Basics.
basics.
Okay, I'm sorry. Neurosurgery Basics uh, with Mila Mangi she's from Saudi. She severely admonished me for getting it wrong. But she's in Russia now. She's a resident. She's put together this webcast, and today excuse me, today she's going to talk about the Carter Equina syndrome, and we'll turn it over to Mila. Thank you very much, Mila. Welcome.
You're welcome. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. John. This webinar was not possible without you. And thank you, ladies and gentlemen, for joining my presentation. Today, I'm going to be talking about Cauda equina syndrome. Let me just share my screen. Okay, can you see my screen?
Yes.
Yes.
All right. Okay, 1 minute. All right.
Yeah, perfect.
It's clear, right?
Perfect.
Okay, Cauda equina syndrome. Why isn't okay? What exactly is Cauda equina syndrome? The collection of spinal nerves that lie within the subarachnoid space distal to the last part of the spinal cord is known as conus medullaris. That's the name given to those specific spinal nerves. Cauda equina syndrome is a neurosurgical emergency. Cauda equina syndrome is also abbreviated as CES. It occurs when there is a dysfunction of multiple lumbar and sacral nerve roots of the cauda equina. For example, starting from L1, L2, and downwards. So here you can see the spinal cord on the left image, and you can see cauda equina, which is also called a horse's tail. And you can see the lumbar and sacral nerve roots. And whenever there is a problem in this section, patients usually come up with certain symptoms. First of all, looking at the right side, here you can see the specific picture of where an inflammation can happen, where there is going to be a herniated disc, and central prolapse can also happen. The nerve roots, they get compressed within the narrowed spinal canal. The cauda equina syndrome, it leads to a syndrome. You have to remember the definition of a syndrome. It's a collection of different problems happening all at the same time. So what is it characterized by? Lower limb muscle weakness, bladder and bowel dysfunction, and abnormal perianal sensation. So 3 things, fairly simple and easy to remember. There's weakness of the lower limbs, bladder problems, bowel dysfunction problems in patients, and patients may complain of their perianal sensations. Epidemiology. There is a low global incidence in the world. Moving on towards the right side. So, what do patients come in with? What kind of histories can you expect to see in a hospital? Well, patients can complain of low back pain, saddle anesthesia. They can also complain of sciatica, bowel bladder dysfunction, or even poor rectal tone. This is just a rough picture which I took. Oh, sorry. Just to give you an idea about how you can easily remember what kind of treatment there is and what cauda equina syndrome might be associated with. Now, if you look at the treatment, there are different types of steroids. The most famous one, dexamethasone, which is normally prescribed. There are different tests which we will be discussing, but you can just remember MRI and CT are the diagnostic tests which patients are required to do. And of course, if it is a major emergency, then surgical emergency, we have to perform surgery. What is this associated with? Trauma, lumbar disc disease, malignancy, or even abscesses. All right, moving towards the MRI. How does it look like? So this is a classical picture of the cauda equina syndrome on an MRI. As you can see on MRI, you can see the entire spinal cord is there's a bump in it, a huge bulge in it. Normally, you can it's easy to see if there is protrusion. It's easy to see if there's a hernia, but this is a classical picture. So try to keep it in mind whenever you're looking at MRIs of different patients, especially neurosurgery, just in case you don't confuse yourself with something else. All right, 1 minute. Okay. What is the acronym? There's a specific acronym, which, oh my God, please just give me a minute. Okay, I cannot see the top of my screen. Can you guys see the top of the screen? 1 minute.
Yes.
Okay.
Using the acronym.
All right. So there's an acronym that we use. Why can't I move? Okay, I've just moved it to the bottom. All right. So what is the SBAR acronym? First of all, you have a situation. Introduce yourself, being the resident doctor on call or being the final year medical student, for example, if you're on rotations. You introduce yourself to your patient and you explain to them the situation. Next, you look at the background. First of all, you have to know how to take history. Without taking a complete history, you will not be able to reach your diagnosis. And if you get your diagnosis wrong, you're doing everything wrong, basically. So you get your history, you understand what kind of physical examination you need to do, you check your patient thoroughly, before going to the third part, which is the assessment. You have to check the different concerns. For example, is your patient, is this an emergency? Do you need to, let's say, call the consultant on call? Do you need to inform other people? Or is this a normal case and there's no current emergency? There's no need for surgery. And finally, the recommendation. Once you have studied your case, you can suggest your patient. Do they need, let's say, IV? Do they need, again, if it's an emergency, they need to go for surgery. You scrub yourself in, you contact people who can prepare the surgery for the patient, you inform the patient what you need to do. Okay, moving towards the top tips. Okay, this is a funny slide. I don't know how to move this. Please give me a minute. Okay, yeah, now I think it's better. All right, so what can you do to save yourself and, of course, your patient? Number one, again, suspect, you investigate. If you have a cauda equina syndrome, you have to check, is it threatened? Is it partial or is it complete? These are possible diagnoses you need to keep in your mind. 3 words. Is it threatened? Is it partial or is it complete? And number 2, you check. Do you need to call a spinal surgeon? You should not call a spinal surgeon first unless the MRI is contraindicated. And of course, looking at the MRI, do you need to check for different pathologies like demyelination? Do you need to check for other areas where the pain is referred? So this is just like a quick guideline to help you, especially when you are working the night shifts or when you're doing your rotations. If we look at the myths at the bottom, the first one, starting from the left side, if there's no urinary retention, it's not cauda equina syndrome. See, this is a myth. There could still be a partial cauda equina syndrome. And these are the patients with the most to lose. By the time retention is established, the prognosis is worse. So remember, again, if you hear someone say this is a myth. It's incorrect. Myth number 2. If the anal tone is normal, it's not the cauda equina syndrome. Nope, another myth. There's no single examination finding excludes cauda equina syndrome. And there's a guideline, it's called the NICE guideline, which says that in mid-2018, this is when it was published, to lower the threshold for urgent MRI. Again, this is a myth. The last myth, the MRI can wait till morning. This is wrong. When you get your patient and you don't have an MRI, it's better to do the MRI rather than delay it for any reasons. Otherwise, you'll have to be explaining your reasons to authorities if, let's say, something goes wrong. Moving towards the causes of cauda equina syndrome. If we look to the left side first, you'll see that we have different categories. There are congenital causes, which are, let's say, spinal dysraphisms. We have the dwarfing syndrome, and there are congenital tumors, for example, like the teratoma and a lipoma. Moving towards the second category, infectious diseases. For example, tuberculosis could also lead to the syndrome, bacterial abscess. Moving towards traumatic, whenever you hear the word trauma, think about a fracture and dislocation. Most common causes of traumatic causes of cauda equina syndrome. Next, degenerative, lumbar disc hernia, lumbar spinal stenosis. If we look at vascular, think about the vessels of the heart, vessels which are involved with the whole circulation. For example, does the patient have any malformations of the arteriovenous system? Or is there an aortic dissection somewhere? Other causes which cannot really be explained iatrogenic. Let's say after spinal surgery, your patient might be experiencing this syndrome. Chiropractic spinal procedures also. Also, this depends in which countries practices are more common. Like in some countries, they're not really found, so you might not really see them. But whereas compared to other countries, this is a major cause of the syndrome. Moving towards neoplastic causes, we have the famous meningiomas, schwannoma, lymphoma, and the metastasis. Endocrine causes osteoporotic collapse. Metabolic, there's a specific disease. This always comes up in exams, and sometimes students forget. It's called the Paget's disease. Also can cause the cauda equina syndrome. Next, the inflammatory causes, which can be rheumatoid arthritis or ankylosing spondylitis. Hemorrhagic, these are your basic hematomas like the spinal epidural hematoma and the spinal subdural hematoma. Of course, last but not least, the thrombotic, the inferior vena cava thrombosis. Now, if we look on the right side, you'll see the causes and the frequency. Another very important question which always comes up in exams. Which cause has the highest frequency? Please remember it's the lumbar disc herniation. It has the highest frequency, totaling 45%. Next is the tumors, followed by infection, then stenosis, hematoma, vascular causes, and then, inflammatory causes, and last but not least, vascular causes. So this is just to give you an idea about all the different types of diseases which can cause cauda equina syndrome. One of my favorite syndromes, by the way. All right, moving towards the symptoms and signs. What can you find in your patient? What is your patient complaining about? Well, patients can complain about saddle numbness. Typical complaint, they will not be able to feel the toilet paper when wiping in the toilet. They might lose the feeling between their legs. A patient might come and explain to you, or they'll feel numbness around their back, passage, or around their genitals. They might also complain of sexual problems, bladder disturbances, bowel disturbances, and last but not least, back pain, sciatica, leg weakness. This is a mnemonic, SPINE. S standing for saddle anesthesia. P, pain, where's the pain? Back and lower limbs. I for incontinence, stool or urine. N stands for numbness around the groin or the legs. E, emergency, urgent surgery. All right, I actually took this slide because this is like a basic summary of cauda equina syndrome. On the right side, you can see the different sorts of physical examinations you need to do. For example, of course, we start with inspection, palpation, then neurovascular examination, since we are doing neurosurgery, so it has to be relevant to your specialization. There are lab studies which we need to check for your patient, and then last but not least, the treatment. However, if you look on the left side, you'll see the prevalence, the incidence, the symptoms, the causes, which we just discussed. And if you concentrate in the middle, the differential diagnosis, many people actually get the DDs wrong when they're writing their examinations. So don't be like those people. Try to understand why we have differential diagnosis. What is the point of even writing differential diagnosis? It's so you can explain to your teachers, professors, consultants, why this disease is different from another disease, because there are specific reasons. And this will help you solve questions and try to get better marks. For example, you can have a spinal cord infarct. You have to check, does your patient have the GBS syndrome? Does your patient have multiple sclerosis? What about a neurosarcoidosis? All important things to remember. All right, the different subgroups of cauda equina syndrome. First of all, if we look at the CESS, what does it stand for? It stands for the cauda equina syndrome. It's a suspect. The S at the end, suspected. Or what do you do when you suspect it? What do you see? Pain. Where is the pain? Where is it localized? Patients feel back pain with bilateral radiculopathy. What changes are there? Well, there could be possible motor or sensory deficits, but here, bladder function is preserved. Your patient will not complain about bowel functions or their bladder functions. Saddle anesthesia is absent, so this is where you can slightly suspect it. Moving towards the second category, the CESI. This is the cauda equina syndrome incomplete. Patients will be complaining of back pain with or without radiculopathy. What can you find on sensory motor changes? It's the same, possible motor sensory deficits. However, your patient will be complaining of bladder dysfunctions. For example, they will have difficulty starting, difficulty stopping, altered sensations, and the bowel function, the sphincter tone is diminished. Saddle anesthesia, it's partial here. This is a very famous question which comes up every year, and many students always get it wrong. So remember, in the cauda equina syndrome incomplete, saddle anesthesia is partial. Moving towards the last category, the CESR, cauda equina syndrome retention. Patients come in with back pain, again with or without radiculopathy. Possible motor or sensory deficits. And moving towards the bladder function, there is painless retention with possible overflow incontinence. And patients also complain of fecal incontinence. Last but not least, saddle anesthesia, complete perianal sensory loss. So this slide is just to give you a different, to give you the information about the different subgroups. Moving towards the worldwide occurrence, like we previously discussed, prolapse disc is the highest incidence, 1.8 incidents per million. Of course, next, trauma, iatrogenic causes, tumor, infection, maybe, following spinal anesthesia. It's very low. There are very low chances of these things happening. Next, what is the difference between cauda equina syndrome versus the conus medullaris? Let's look on the left side, the anatomy. Conus medullaris, it occurs most distal part of the spinal cord, whereas cauda equina, as I previously described, descending spinal roots. Vertebral level, L1, L2 for the conus medullaris and cauda equina syndrome, L2 and below, including sacrum nerve roots. Spinal level, sacral nerve roots, and then the lumbar sacral nerve roots. Onset for conus medullaris, there is sudden and bilateral onset, whereas cauda equina is gradual and unilateral. Presentation, conus medullaris symmetrical, and the other one is asymmetrical. Moving towards the sensory. So conus medullaris has saddle anesthesia, whereas in cauda equina, I just described that. It depends on which category you are talking about. And moving towards the left side, the right side of the picture, I want to discuss reflexes. In the cauda equina syndrome, both knee and ankle jerks are lost or diminished, maybe asymmetric. Whereas in conus medullaris, only the ankle jerk is lost. Plantar reflexes, it's flexor plantars in cauda equina, and in conus medullaris, it might be the extensor plantars which are affected. So this is to give you an idea between both conditions and what you can expect if you have a patient. All right, this is one of my favorite slides because what questions do you ask during your history? The first question, do you have difficulty starting to urinate? What do you think about urinary hesitancy? Number 2, can you feel yourself passing urine? What do you think about reduced urethral sensation? Number 3, do you experience dribbling after urinating? What do you think about overflow incontinence? The fourth question, when you try to pass urine, is it painful? What do you think about painful retention? Does my patient have this, or doesn't he, or doesn't she? Can you feel the toilet paper and does it feel normal? immediately think about saddle anesthesia. Last but not least, have you noticed any recent change in your ability to maintain erections? What are we discussing? Sexual dysfunctions in patients. So this slide, please feel free to save it because it's very important. There are only like 6 questions, but very important to reach a correct diagnosis. All right, moving towards investigations. What do you have? What do you suggest? Number 1, you have your plain X-ray. Number 2, you have a CT. It can be with or without contrast. There's a specific point I want to mention. MRI is an important investigation, but if it is contraindicated in patients, for example, if your patients have pacemakers or metallic implants, you cannot use an MRI. Instead, you have to use the CT with or without contrast, depending on the condition. After that, the lumbar myelography. Last but not least, to check for the bladder problems, we do the bladder ultrasonography to measure post-void residual urine volume. It's also abbreviated as PVR. I don't know if you guys notice, but if you've ever done rotations or if you're ever taking histories, you can see that at the bottom of the list of investigations. It's always abbreviated, it's always there. So now you know what it means, post-void residual urine volume. One thing which is important to remember is if the PVR value is more than 100 ml, this is defined as incomplete bladder emptying, and catheterization is required to reveal neurogenic urinary retention. Moving towards management. So we have the clinical categories. Number 1, let's say you've done all your investigations and you find out that your patient does not have the CES. What do? You admit, check pain relief, and you do an MRI the following day. What if you have a patient who has a high risk of developing the CES? Presenting features, these are red flags, but there is no feature of CES itself. So again, you admit the patient, give them pain relief medications, and you conduct an MRI the following day. Number 3, if there is a patient with the CESI, what do? This is an emergency. You conduct an emergency MRI. You check, does our patient need decompressive surgery? Does our patient need, do we need any other important things to like check if the emergency is, should we do that right now, or can it be scheduled after a few hours? All of these important questions. Number 4, if your patient has bladder paralysis, this is a neurosurgical emergency. You have to perform surgery as soon as possible. All right, moving towards the questions. Please feel free to unmute. I want to see if any of you know the answers. 3 simple questions, and I hope you guys can answer them. All right, the first question. Cauda equina syndrome occurs when nerve roots at the caudal end of the spinal cord are compressed or damaged. Of the several causes of this disorder, which of the following is most common? A. Congenital neurologic anomalies. B. Herniated disc. C. Spinal stenosis. Or D. Spinal cord infection. Feel free to type it in the chat, or if anyone wants to unmute, they can give a shot at this question. Anyone?
Yeah, I'm gonna be the mini teacher. And Sonatus, I wanna ask you, you're on the stage, buddy. What's the answer?
Wait, let me.
Okay.
Sure, take your time.
Okay.
Tick tock, tick tock, tick tock, tick tock.
B.
All right,
Okay.
so Dr. Johnson's
Oh my,
answer.
oh my God. If I had symbols, I'd crash them together.
Thank
All
you.
right. So number B, herniated disc. Okay, some people C, D. All right, so time to reveal the correct answer. Okay, let me take you back a few slides. If you all remember, I had discussed this in, I think in this slide. I
Mm-hmm.
did tell you that the cause, the highest frequency is the lumbar disc herniation. So it's 45%, and Dr. Johnson got it right. The answer is herniated disc because the question clearly specifies which of the following is most common. So number B, correct. Well done,
Okay.
Dr. Johnson. Let's see if you
Thank
can
you.
answer question 2. All right,
Okay, you know, Mila, I don't think you see it, but in the chat, there's a couple of participants. Akil from Basso said B and C, so he got it partially
yes,
right. And
yes.
someone else said D, and Bajaji from from India, a neurophysiologist, said B also. So he also got it right.
Very
Okay.
good. That's great.
Okay.
Now,
John, may I add something, please?
Yeah, sure,
sure.
of course, of course.
The question was a little bit difficult because she asks at the end of the spinal cord. Most of people thought maybe at the level of the conus. This is the reason the answer were not correct.
Yes, that's true.
Oh,
This is
is
a
that
trick
true?
question.
Oh my God, we were busted.
This is not my question. This is a question which came up in one of the exams last year. So
Oh, okay.
one of the reasons I'm sharing
So
it. But
you
yes,
won't be punished. That's okay.
that's good. I hope you can all answer the second one. All right, this is the second question. The symptoms of cauda equina syndrome are varied and, if left untreated, can lead to complete paralysis of the lower extremities. So, it is best to determine if a patient has cauda equina syndrome in order to provide immediate treatment. Which of the following symptoms, if present, suggests cauda equina rather than spinal cord injury due to trauma? A. Bladder and bowel dysfunction. B. Decreased deep tendon reflexes in the legs. C. Paresthesia. Or D. Sensory loss. Does anyone want to try?
I think it's
Sure.
A.
Sure,
I
okay.
think
Okay, Akil from Bassa said A.
All right.
Lujane said A and D. I don't know where Lujane takes
I
tests, but
think
you
A.
can give one
A.
answer.
Oh, yes, Lejane, there's only one correct answer because this is a best choice question. It's not an MCQ. So just choose one.
A.
Okay,
Okay. Sonata
A.
says B.
A. A.
A, okay.
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 Does anyone
Okay.
else want to try?
Oh my God, they all said A.
All right. Unfortunately, A is incorrect.
Oh my God, we're all wrong there.
I'm sorry,
That's
but the
okay.
correct answer is B, and I will now explain why.
Okay.
Okay, so let's look at why the other options are like not correct. Okay. Number A, why is A wrong? Bladder and bowel dysfunction are symptoms of both spinal cord injury and cauda equina syndrome. So, according to the question, you have to choose which one is cauda equina rather than spinal cord. But option A occurs in both conditions, so A is incorrect. Now, the people who said choice C, I don't know if there was anyone who said C or D, but we can just discuss it. Paresthesia is a symptom of both syndrome and the injury. Again, it's both, so you cannot choose C. Number D, Loss of sensation is a typical finding in patients with cauda equina syndrome as well as spinal cord injury. Again, all three options are found in both conditions, except B. Now, why is B correct? Decreased deep tendon reflexes in the legs. In cauda equina syndrome, unlike in subacute or chronic spinal cord injuries, deep tendon reflexes are decreased in the legs. However, in an acute spinal cord injury, if an acute spinal cord injury is severe, muscle tone and deep tendon reflexes are usually decreased or absent. Spinal shock, for example, making distinguishing it from cauda equina syndrome difficult soon after injury. So I know this is a trick sort of question, but the correct answer is B. And this explanation makes sense. Think about it. You have a patient who just suffered an acute spinal cord injury. It's severe. Will the muscle tone and will the reflexes be increased or decreased? According to common sense, logic, and like understanding the way spinal cords work, because the injury is severe, the tone will be decreased, if not absent. For example, if there is shock, there's not going to be any movement in their muscle tone. So I hope this question was not too difficult, but we can try the last question. All right, this is the last question. A 66-year-old woman comes to the emergency department because she has had low back pain and loss of sensation in her left leg for the past several days. She says that she had a few episodes of bladder and bowel incontinence. Based on these findings, which of the following is the most appropriate initial step in diagnosis? A. CT scan of the spine. B. MRI of the spine. C. Ultrasonography of the spine. Or D. Spinal X-ray. Does anyone want to try or type it in the chat?
That's a good question.
B.
Oh, sorry.
B.
Okay, Doctor.
Sonata says B.
All right. Anyone else? In the chat.
Okay. Lucien says A. Akil Bombaso says B.
All right.
Couple others are A. Okay.
All right. Now we can discuss this.
Okay.
Explanation. Oh, wait. No. First, let me tell you the right answer. Sorry. The right answer is actually B. It's not A or C or D. There is a reason for this. Let's
Okay.
discuss the reason. Let's look at the wrong choices. So option C, ultrasonography, is not as effective as an MRI for diagnosing cauda equina syndrome. I did discuss this in my presentation that you only order a bladder ultrasonography when you suspect bladder problems. And but according to the question, you have to select the most appropriate initial step in diagnosis. This is why we cannot go for C. You only choose option number C when the question would be like, what are other steps can be taken after, let's say, the first step. Then option C would be correct. Moving towards option D. If a patient has sustained a fracture that is causing cauda equina syndrome, then X-ray studies should be done. It is not, however, the most appropriate initial diagnostic test. All right, fairly simple explanation. If you suspect a fracture, you go for the X-ray. Again, it's not the most appropriate initial step. Let's discuss B. MRI of the spine. Immediate MRI is the best test for diagnosing cauda equina syndrome. CT myelography and not CT scan, which was choice A, is another possible test, especially if MRI is not available. Again, the thing with questions is that let's say if option B did not exist, or if option B was something else. In that case, you can't select option A as a correct answer. But you have to be very careful when you're doing questions like this. You have to be careful with all the information written in the question. one word can change the entire answer. It can change your entire diagnosis. So these were just like 3 practice tests. I hope you now are able to understand the causes, the symptoms, the signs, the investigations we need to take, and of course, the treatment for cauda equina syndrome. If there are any questions, thank you very much. You can feel free to contact me. That's my email address at the bottom. Thank you, everyone.
Excellent, excellent. The questions at the end were really good because it really makes you think of different aspects of your presentation. I'm going to actually suggest that to some people. It's a good way to end the webcast. Really, kind of review of what you saw and put your mind to work. So, yeah, any questions or comments
Any
from any
comments?
in the panel?
Thank you so much, doctor, for the lecture. It was so effective.
Problem.
Dr.
Glad you
Mila,
enjoyed.
it was also very interesting. So thank you. It was interesting.
Akil, where you from? Where you from, Akil?
Me, doctor? I just changed my number, doctor, because my another phone have a problem. I am coming from Cameroon.
Oh, excellent. Welcome.
Yes, sir, doctor. Thank you.
Okay, Lujane, you are from? I don't
She's
know
my
if you-
friend. She's in Moscow.
Oh, okay. Okay, yeah, this is a good touch to add to the lecture. Okay. Yeah, definitely, we're going to explore the Arabic sector of the world because as Mila says, she's from Saudi. And we're going to experiment. And that's the beauty of this platform. We can just run another webcast, try it. It doesn't work. We just don't do it anymore. That's all.
Yes.
That's the beauty. We're not locked into, 6 months of grand rounds of Cameroon or whatever. We'll just go with the flow and
Yes. We
let
can
people
experiment.
participate. We can experiment, see what platforms you use. I'm not a neurosurgeon, but I'm more or less doing a residency in video production, trying to learn what makes some conferences go well and some that don't go well. Certainly, pre-conference organization is key for someone like Mila to reach out to the main people, hopefully, in her neurosurgical community. And we have the use of social media. I find Facebook and WhatsApp to be the best way to get the word out about your webcast. So stick around and we'll chat some more. And
Thank you.
This is the end of the formal presentation. Stick
Thank
around
you.
and
Bye.
network. Thank you.